This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hey, this is Jason Crowell from Norton Neuroscience Institute in Louisville, Kentucky. Thanks for listening to today's Neurology podcast. I'm very excited to welcome Bastiaan Bloem to the podcast today. Bas is a neurologist at Radboud University Medical Center in the Netherlands. Bas recently was the co-author of a paper that was published in Lancet Neurology in January of 2023. The title of this paper is Research in Movement Disorders in 2022, a New Era of Biomarker and Treatment Development. Bas, thanks for joining us today.
Thanks for the invitation.
This is a bit of an atypical interview for us. So we typically cover research articles, and this rather as a survey of several different papers from 2022 that were important in the world of movement disorders. And I'm a movement disorder specialist, so I readily admit my bias here. But what I thought would be useful is for you to kind of hop in the car and take us on a tour around the neighborhood and highlight and point out some of these papers from 2022 that you all describe in more detail in the paper that you published. So what we'll do is we'll go through and touch on several different research areas from 2022 that were important in the world of movement disorders. And please feel free to jump in and share any observations you have. Does that sound good?
That sounds excellent.
So the ones that I wanted to start with have to do with potentially disease-modifying treatments for Parkinson's, which unfortunately did not have positive results, and we can talk more about that. So the Pasadena study, which looked at prasinezumab, and Spark, which looked at cinpanemab. So can you tell us what were these two drugs hoping to do, and what did we learn from these two studies?
As people know, Parkinson's is a relentlessly progressive disease, and while we're good at treating symptoms and signs, there's currently no established way of slowing down disease progression. And one of the great hopes is that by targeting the underlying disease pathology, the pathophysiological process, we might be able to slow down disease progression. And as we've known for decades, one of the hallmarks of the disease is Lewy bodies in the brain that we now know contain pathologically misfolded protein called alpha-synuclein. And one of the approaches that has been tested now in a number of trials is antibodies that specifically try to target the alpha-synuclein misfolding by sending these antibodies and hopefully prevent the misfolding from happening. And two large studies, as you mentioned, both studying a monoclonal antibody, now been tested in large numbers of participants in a randomized controlled trial. Both studies were published in the New England Journal of Medicine, so very decent journal. And unfortunately, although both studies were well designed, adequately powered with an adequate follow-up, there was no sign of efficacy on clinical outcomes, the Unified Parkinson's Disease Rating Scale, nor on a dopamine scan of the brain, the dopamine transporter scan. So there was no sign of target engagement. There was no sign of clinical efficacy. And obviously, this was disappointing for the field. We've seen many disappointments in the Alzheimer field where targeting amyloid was not always successful, with maybe one exception. But definitely, these were two disappointing outcomes in the field of Parkinson's.
So I know this is still a topic of much debate, whether or not targeting alpha-synuclein is going to be fruitful. We're recording this in late April, and I was just reading last week an opinion piece by Tony Lang published in Movement Disorders Journal, again, discussing this idea of whether or not targeting alpha-synuclein is the way to go. Can you comment on that? And I know this is opinion, but can you comment on these monoclonal antibody treatments for Parkinson's? Do you think this is something that should still be looked into, or are you in the camp that this is unlikely to be effective with regards to disease modification?
As you said, there's two camps, and I'm sort of halfway in between. One camp says, well, how many negative trials do we need before we bin the whole idea of anti-alpha-synuclein treatments? And that's one way to go. What we discuss in our paper in the Lancet Neurology is that there are perhaps two avenues to do things better. And one relates to the clinical outcome. I mentioned the Unified Parkinson's Disease Rating Scale, and any listeners who've used this scale in their clinical practice know that this is an observer-based rating scale where you look at symptoms and signs and you give it a score from 1 to 4, which means it's an ordinal scale with fairly big steps. And we know that this clinical scale is subjective to intra and inter-rater bias and variability. So people feel that maybe we've missed the boat by not including a more sensitive, objective, for example, digital biomarker. And what I thought was really interesting, and which did not receive a lot of attention in the paper, is that in the Pasadena trial that tested the prasinezumab, they also included an exploratory digital outcome. And specifically what they did is they used the participant's smartphone to deliver a series of tests on a very regular basis, where people were asked to hold the phone in their outstretched hand to measure tremor, to make alternating movements to test for bradykinesia, to make a sound, and to listen to the voice. And interestingly, in a separate experiment, they validated this digital outcome by showing it showed a fairly decent correlation to the Unified Parkinson's Disease Rating Scale. But now the difference being that you can deliver this much more frequently and at home on a continuous basis. And what is interesting is that even though the clinical outcome did not show any difference in the Pasadena trial, the digital outcome did show a benefit for both active treatment arms. They compared a low dose and a high dose to placebo versus the null treatment, the placebo treatment. The only concern here is that the higher dose had a smaller effect than the lower dose. So that is not really intuitive. And of course, this is only exploratory. So you cannot overinterpret these findings. It's at best exploratory. But I think it does raise the question whether future trials should continue to rely on this complex, subjective, and variable scale, which is called the UPDRS, or whether we should now increasingly move towards digital outcomes, because there are advantages. It's objective. It can be delivered much more frequently and at home. And I'm a strong believer in digital outcomes. So I think one of the major, results of the Pasadena trial is that it shows the potential of a digital outcome. Now, obviously, what you need to show is that a change in a digital signal means anything to the participant. And what the FDA is now increasingly demanding is an outcome which is neither a clinical rating scale nor an arbitrary digital signal, but something that's meaningful to the participant. Can I now fry an egg with this tremor? Can I go out and about and do my shopping independently? This is where we need to go to clinically relevant outcomes. And ideally, we build digital measures that show some correlation to these clinically meaningful daily activities for patients. And this is a field that's now up and coming. We're also active in that field. And again, I think this is one of the major sort of outcomes of this negative trial, to my mind.
That's a great point. And let me follow up on that. So in this study, they were using some kind of app in a handheld phone. Is that correct?
Yeah, that's correct.
And are there other types of devices currently being employed that can facilitate measurement of some kind of biomarker other than an app and an iPhone?
Yep. Well, one paper is discussed in the Lancet Neurology editorial that I wrote, by the way, with my good colleague and friend, Christine Klein. Her name should be mentioned in this podcast, of course. The other study that we mentioned, and I thought this was really interesting, used radio waves by a device that was attached to the wall in the house of the participants. So by and large, these digital biomarkers are now based on body-worn sensors, whether this be a smartphone or maybe a smart watch or a sensor attached to the waist or to the chest or to the ankle. The big issue there is compliance. And what Ray Dorsey and his group have shown is that radio waves transmitted from a device attached to the wall can actually measure movements while people are moving out and about in their own homes. And they specifically looked at gait. In a separate paper published in another good journal, they looked at breathing patterns. And apparently, these devices can unobtrusively measure the quality of gait in people's homes. It did not show a good correlation to disease progression. That was a bit of a downside, but it correlated reasonably well to the MDS-UPDRS rating scale. And the great advantage here, of course, is that you can now measure people's quality of movements without having to attach anything to their body. So potentially, this will be very good from a compliance standpoint. Disadvantage, of course, being that you can only measure people in their homes and not, for example, when they go out on the street to do some shopping. But it's an interesting development, and it just shows that this whole field of digital biomarkers is developing rapidly. And for all the people listening today, this will impact in the short term only on clinical trials, where these digital outcomes will be used as secondary exploratory outcomes. I don't think that in the short term it's going to affect your clinical practice, although I hope and I would predict that within, say, 5, maybe 10 years, we will come to a point where the patient comes to your clinic showing a readout of their smartwatch, their smartphone, maybe the radio waves transmitted from their wall, so that you can interpret that signal in a meaningful way and then adjust your Parkinson medication accordingly. I think that time will ultimately come, but it's not here yet.
Bas, you also in this paper mention some other biomarkers for Parkinson's disease that are still being developed. And again, we're recording this in mid to late April, and the American Academy of Neurology annual meeting is currently underway. And so some results are being discussed there. But at least in this paper, can you talk about any of those biomarkers that stood out to you?
What you would like to show is the nature of the underlying disease process in the brain. And we mentioned alpha-synuclein as a key protein that misfolds and clots in the brain of Parkinson patients. We knew already that there are tests called seeding assays, where in a prion-like manner, you very cleverly ask the protein to replicate itself. So it's a very sensitive way of showing minute concentrations of alpha-synuclein in body fluids. And this had already been demonstrated in cerebral spinal fluid, for which you need a lumbar tap. But now a new paper in Brain showed that this alpha-synuclein can now also be measured using this seeding assay in blood. And that is, of course, very important. They were able to show that it separated Parkinson patients from controls in a rather good way. They were even able to show that the alpha-synuclein that they measured had a pathological structure. And that's important because one of the other reasons why the Pasadena trial and the Spark trial were negative is that maybe people were included in those studies that never had an alpha-synuclein problem to begin with. So if you now have an assay, ideally one in blood, because it's readily accessible, that can show the nature of the underlying disease process and where you could prove that your participant actually has an alpha-synuclein issue, then you would be a good candidate for an alpha-synuclein antibody study. And you just mentioned the AAN, and I'm unfortunately not in Boston, but I know what they're discussing because last week another paper came out in the Lancet Neurology based on the PPMI data, where they used another alpha-synuclein seeding assay, this time in the cerebral spinal fluid, to show two things. One is, if you have idiopathic Parkinson's disease, i.e. not any of the known genetic causes of Parkinson's, the test is positive in around 96% of participants. But if you have LRRK2 Parkinsonism, which is one of the autosomal dominant causes of Parkinson's disease, the test was only positive, I'm saying this off the top of my head, in some 60 or 70% of participants. Now, if you hadn't done those tests and you had included LRRK2 positive individuals in your trial, many of whom never had an alpha-synuclein problem, you would be underpowered to detect a real effect. So the fact that we now know that Parkinson's is a heterogeneous disease in terms of pathophysiology, and that we have tests in CSF, but perhaps also in blood, as this new paper in Brain was showing, you can identify the right candidate for the right study. And that, I think, is a major development, again, for trials, not so much for clinical practice yet, but it will allow the right people in the right studies.
Very good. And so, Bas, any other highlights from the research world and movement disorders from 2022 that you think we should know about?
Well, two things that I think are attracting a lot of attention. One is the close link between Parkinson's and diabetes. Number of studies have already suggested that there's a link between the two. A new paper in movement disorders showed that people with Parkinson's and concurrent or comorbid diabetes had faster disease progression, which again confirms that there's this link between Parkinson's and diabetes. And that is a strong further motivation to use anti-glycemic drugs as a potential way to modify disease progression in Parkinson's. To my mind, one of the most promising compounds around is exenatide. There was a paper in the Lancet by Tom Fultoney's group in England to show that exenatide was associated with a slowing of disease progression in Parkinson's in a phase 2 study. Tom is now performing a phase 3 study in England using both clinical outcomes and digital outcomes. And I think out of all the many compounds that we're currently testing for possible disease-modifying potential, I think these anti-glycemic, these diabetes drugs hold the greatest promise. So I think that's one thing that people should be aware of. And also, maybe for those in daily clinical practice, to just be aware of these comorbid conditions. You know, people with Parkinson's don't just have Parkinson's disease, they typically have multiple other conditions, and one of the common ones is diabetes. The other thing that I would like to mention, because this is a question that comes to my desk in my clinical practice a lot is the relationship with SARS-CoV-2, the COVID infection. There have been a number of case reports where people following a COVID infection developed Parkinson's disease shortly thereafter, triggering a debate whether COVID or the SARS-CoV-2 virus, which we know is neurotropic, could also affect the basal ganglia and thereby maybe cause Parkinson's disease. There's been critique of these studies. We actually published 2 cases where we showed that people who developed Parkinson's shortly after COVID, in fact, already had prodromal Parkinson's, if you listened carefully to their stories. So maybe COVID just unleashed what was already about to happen because of the stress associated with a COVID infection. But there's a new paper in movement disorders where they looked in a mouse model where they infected mice, rodents, with COVID and subsequently exposed the same rodents to a neurotoxin called MPTP, which we know is a potent toxin for the substantia nigra, and showed that mice with prior exposure to COVID were more susceptible to a neurotoxin that caused Parkinson's. So jury's still out there. We're not certain whether COVID is definitely leading to Parkinson's all by itself, but it could potentially interact with other triggers in our environment, jointly lead to Parkinson's. I don't think we've seen a massive further increase in the number of new cases with Parkinson's since COVID, but time will tell. We need to monitor this, and I think it's an interesting basic observation.
Terrific, Bas. Really helpful tour of some of the updates in research and movement disorders over the past year. To our audience, again, the title of this paper published in Lancet Neurology in January of 2023 is Research in Movement Disorders in 2022, a New Era of Biomarker and Treatment Development. Again, this was co-authored by Christine Klein and Bas Bloem. We've been speaking to Bas. Bas, thanks so much for joining us. We really appreciate your time today.
You're more than welcome.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.